Good evening.
Good evening.
How is everyone this evening?
Good.
Great.
This is the first monthly meeting after the time change. It's so dark outside.
Dark in Canada too.
Who's that?
I said it's dark in Canada too.
Yes, I could imagine that. And cold.
No, it's actually very warm today. Indian
Where are
summer.
Where are you?
Georgian Bay. We're relatives of Dr. Don.
Okay. Oh, Georgian Bay. Okay. Out west.
No, in Ontario.
Ontario. Okay. How warm is it?
22 degrees Celsius.
Indian summer.
Yeah.
I guess all the leaves have changed. All the leaves changed color.
They're all gone now.
Okay. All right. Great. So where exactly is where you live?
Just about 2 hours north of Toronto.
Okay. 2 hours north. That's a lot. That's far away.
Not to us.
Well, I think we had what 80 degrees today. I guess that's almost 30 degrees Celsius, but 22 degrees is still warm for you.
Yeah, it's good.
We're going to wait a few minutes before we start to get a few more participants, so we make it worthwhile for people. 5 more minutes, maybe. I guess we had a lot of rain from that so-called tropical system, and hopefully the other one that's brewing doesn't come this way, but it's a possibility.
Do we have anybody celebrating birthday the month of November?
No birthdays. No birthdays, Aaron.
No birthdays? Unbelievable.
My daughter's birthday.
Happy birthday to her.
Yes, Don is. I see Don is here. Don's almost ready to go. Hey, Dr. Major can't wait to go.
Yeah, ready when you guys are.
All right, good. Aaron?
Let us
Aaron, you still
pray.
there?
Yes, I am here.
You want to open us up with a little prayer?
Let us pray. Thank you, Heavenly Father, for this day that you've given us. Thank you for health, strength. Father, we thank you for the message that Dr. Major will be presenting to us. May it educate us, bring awareness, and those that are coming on stream, dear God, let us understand what is given to us tonight. We thank you and we give you all the glory and praise. In Jesus' name, amen.
Thank you, Aaron. We could go over a few things in terms of business and announcements before we give Dr. Major his the floor. I see the lockdown has freed up us a little bit in terms of a couple hours. I guess lockdown changed to what, 9 o'clock now? Or curfew, sorry, curfew. And
yes,
we get some parts of the weekend back, so we'll see. Hopefully the COVID doesn't flare up again, but you know how it is. It may. I see so many cars still on the street there. But anyway, everybody trying to rush home before curfew. I see Aaron is still at work.
As always.
Yeah, it's been a long day for me too, but anyway, yes. Just want to make a couple announcements. At the end of this month, this Friday after Thanksgiving, Thursday, we hope to still have our Love Lights a Tree ceremony, where the Christmas tree is erected at the mall at Marathon outside CIBC. The tree isn't here yet, but we hope that it will come. We still have what, two or 3 weeks to 2 weeks to go. Hopefully you'll make it. And our ceremony will depend on what the lockdown will entail, but we plan to have it a little earlier than usual. We normally would have it at 7 p.m., but since lockdown is at 9, we probably will move it to 5, right, Aaron? That was the plan?
Yes.
All right. And one of our co-chairs for that Love Lights a Tree, Omega, is working diligently to get the program together, and hopefully everything will mesh together and we'll have it for the 27th of November. Following that, we also have another little event planned, and again, that depends on the curfew issue. We were planning to have a little, event at the Cancer Society grounds on December the 10th, put on by the Blue Rose Foundation, and they're gonna highlight children's cancers, and Mr. Bo is heading that function, and we will still get some details in short order in terms of what that will entail. I think part of the event will I hope it's still on, but part of the event was to have a little art competition, and hopefully that will also go on as well. The art competition is within the schools, and they will select the winner at some point, and then the prizes will be presented at that event, as well as other things. Freedom Kids also is involved in that event, whereby hopefully the children with cancer get some Christmas gifts. Every year, this group puts on a little Christmas party and give children gifts around Christmas time. So hopefully all that can be arranged, and that's scheduled for December the 10th. And I think that's supposed to start at 4 p.m. in the afternoon. And again, that will depend on the curfew and the COVID situation. So those are the 2 main events coming up for us. Oh, sorry, now one other thing too. We are still also planning a New Year's Eve ball. And Aaron, give me the title theme on that again, because I wasn't at the last meeting.
It's a grand virtual fantasy New Year's Eve ball,
Okay,
which is going to be on December 31st, and it's in the comfort of your own home.
Okay.
So it's basically celebrating New Year's Eve. You know, you can't go out much places because of the social distancing. So, you know, persons may still want to get dressed up and celebrate, but we also would like for you to help donate to the Cancer Society during that time.
So those are the 3 main things we have left for the year. I understand that throughout this year, we were unable to do much fundraising, but hopefully with these with these 3 events coming up, the Love Lights a Tree, the Blue Rose Foundation event, as well as in the New Year's Eve ball, we can raise a few extra dollars to help with the running of the Cancer Caring Center. That's all the announcements I have for now. Unless Aaron, did I miss any?
No,
Okay.
that's
So
about it.
the last month we had our own Dr. Curling, who is a board member of the Cancer Society, speak on breast cancer. This month we're having Dr. Don Major. Dr. Major is a consultant at the Princess Margaret Hospital as well as Doctors Hospital. He went to medical school at UWI and went on and did the Doctor of Medicine surgical program here in the Bahamas, following which he went off to Calgary, Canada, and did a fellowship in surgical oncology and hepatobiliary surgery at the Foothills Medical Center and the Tom Baker's Cancer Center in Calgary. So tonight, he's going to speak on pancreatic cancer. I know pancreatic cancer is in the news this month because one of the Alex Trebek from Jeopardy passed away, and he had pancreatic cancer. And I guess he'll highlight some of the signs and symptoms and how we deal with pancreatic cancer in his talk. So Dr. Major, the floor is yours and carry on. Thank you.
Good night, everybody. Can you hear me?
Yes.
Okay, I'll share my screen. Well, first of all, I'd like to start by thanking the Cancer Society for granting me this opportunity to discuss what should we all know about pancreatic cancer. As Dr. Shea said earlier, I am a HPB and surgical oncologist surgeon. That means that I operate on cancers most days. And most of the cancers that I operate on are intra-abdominal, and I do some skin cancers as well. But pancreas is one of my favorite organs to operate on. It's also quite challenging organ to operate on, but I like to undergo the challenge. So without further ado, what should I know about pancreatic cancer? So we're just going to kind of go through a brief anatomy and physiology of pancreas cancer, some of the types of pancreatic tumors, risk factors, as well as diagnosis, treatment, follow-up, and in conclusion. Presently, I have nothing to disclose. So if we look a bit at the anatomy of the pancreas, it's considered a retroperitoneal organ, which means, yes, it's in the abdomen, but it's behind everything. So as you can see in this picture here, we have the stomach lying just over top of the pancreas, and the head of the pancreas is intricately applied to the first part of the small intestine, which is known as the duodenum. It's also closely related to the gallbladder, and then there's the bile duct that actually drains through the head of the pancreas. And you can see where, as we get on in our talk, where this can actually cause problems related to certain tumors. And then you also have the liver that's just above the pancreas. You have the right and left lobes. When we look a little bit closer at the pancreas and its arterial anatomy, we see that there are two main vessels that run through the neck or behind the neck of the pancreas. And these main vessels are the superior mesenteric vessels that supply all the blood to the small intestine, as well as the first part of the large intestine. These are important vessels to look at when we are examining our CT scans and MRIs to determine whether or not a lesion can actually be removed safely without causing compromise to the remainder of the organs. It also divides the pancreas into a pancreatic neck, as you can see here, and then the head is the portion that's intricately applied to the duodenum. Then you also have a body and a tail. The pancreas itself, when you look at it, it has two main functions. It has an endocrine function, which we all know about when we talk about diabetes. So we look at the insulin production, and then it also has an exocrine function, which helps us to digest fats, proteins, and carbohydrates when we eat our meals. So if we look a bit more at the exocrine function of the pancreas actually stores enzymes in their pro-enzymatic form. So they're pretty much dormant within the pancreas. They don't have any function at that point in time. But when we eat our food now, the pancreas is stimulated to actually secrete these enzymes into the lumen of the small intestine or the duodenum via the pancreatic duct. And once they're in the duodenum now, they become their active form, which actually starts to now digest your proteins and also digest your fats as well as your carbohydrates. That's the exocrine function of the pancreas. When we look at the endocrine function, which only makes up, the cells only make up about 1 to 2% of the pancreatic substance, we have the alpha cells. These are made up of about 20% of the islets of Langerhans, which are the endocrine cells of the pancreas, and they cause an increase in blood glucose when our blood sugars are low. Then the ones that we all know about is the beta cells that secrete insulin. So whenever we have a high blood sugar, the insulin levels or the pancreas is stimulated to secrete insulin that cause the insulin levels to rise and the glucose levels to fall. There are also other enzymes or other endocrine cells, such as your delta cells, that secrete somatostatin and your F cells that secrete pancreatic polypeptide, which have other functions related to the pancreas. Now, what we all came here for about tonight is that of pancreatic tumors, or pancreatic cancer to be specific. Pancreatic tumors themselves can actually be arranged into two types, or two main groups. You have the exocrine tumors, and then the neuroendocrine tumors. The exocrine tumors with adenocarcinoma of the pancreas accounts for the majority of pancreatic tumors, or pancreatic cancer. This is what we think of when we talk about cancers of the pancreas. So pancreatic ductal adenocarcinoma. It's actually the 12th most common cancer related to the body, but it has one of the highest mortalities for any malignancy. By the year of 2030, it's actually projected to become the leading cause of cancer-related death. In 2019 alone, there were 56,770 people that were actually diagnosed with pancreatic cancer. Of these people in the US, 45,750 of them died. That's nearly an 80% death rate. When we look at 5-year overall survival, which basically means from the time you're diagnosed with cancer to 5 years later, how many people are still around? When they look at all comers, regardless of your stage, if you're early or you're late, only 7% of people who were diagnosed with pancreatic cancer were still alive at 5 years. So imagine if you have 100 people and they were all diagnosed with pancreas cancer, in 5 years, only 7 of them would be around. Now, if you add surgery to this mix, that goes up to about 12 to 15% overall survival. And then when we look at that same 100 people, and we take a median number, which is 50, 50 of them will be alive at 25 months. Some may go on to live out a bit longer, some may be a bit shorter than 25 months. But the median survival for these individuals would be 25 months. The good thing about pancreas cancer is it tends to present later on in life. So in the 6th to 7th decades. When we look at WHO and their GlobalCon data in 2018, so this is the worldwide data for all the different types of cancers, we see in the yellow here that pancreas cancer was diagnosed in 458,918 people. That was in the year 2018. Of those diagnosed, 432,242 people actually died. So as Dr. Shea was pointing out earlier, Alex Trebek, I think he was diagnosed with cancer probably about a year ago, and sadly, he's not here. Now, when we look at pancreatic cancer for the Bahamas, our local population, there's limited data out there. Recently, there was a paper that was published at the Caribbean College of Surgeons, done by Nottage et al., that actually reviewed the patterns, distributions, outcomes of pancreatic cancer at the Princess Margaret Hospital from the years of 2008 to 2017. During that time, we did 20 pancreas resections, which isn't a lot, but again, it's the 13th most common cause of cancer. The most common procedure that we did was a Whipple's operation, which I'll talk a bit more about further in this presentation. And we found that the median survival for our individuals was around 12 months. So why is it? Why is it that this cancer is so deadly? Why is it that people within a year of diagnosis, they're dying? The main reason being is that there are no early warning signs. By the time this thing presents itself, or by the time you figure out that you have pancreas cancer, it's already too late. The majority of people who are actually diagnosed with pancreas cancer, only about 20% of those you can actually operate on with an intent to cure. So that means 80% of people, they have to get some other form of treatment, whether it's chemotherapy, radiation, or just palliative treatment. And the only way in which you can actually get some form of long-term survival or outcome is to actually remove this thing in its totality. that it being the mass or the cancer itself. So let's look again at who's at risk for pancreatic cancer. We may not be able to tell you if you have it early on. We may be able to kind of define who may be at an increased risk as compared to the normal population. So when we look at the risk factors, the main ones that are common to most all cancers: tobacco smoking, heavy alcohol use, high body mass index or excess fat, lack of exercise. And this is a problem that plagues the entire world. We all have issues with exercise, or we're a little bit overweight. Some of us drink, some of us smoke. And these are the main risk factors for developing pancreatic cancer. And when we look at body mass index or BMI, it's a better evaluator of if you're overweight or not, or if you're obese or not. So the BMI just takes the patient's body weight and put it over their height, and it gives you a number. And that number kind of tells you if you are underweight, normal weight, overweight, or obese. It's a better relator than how heavy you are on the scale that day. There are also other risk factors such as genetics. So some people have an increased risk of developing pancreas cancer because they have family members that may have pancreatic cancer. And there are individuals with prediabetes or chronic pancreatitis. Long-term diabetes also increases your risk of developing pancreas cancer. If you have a family history of pancreatic cancer or family history of pancreatitis. And finally, contact with chemicals and heavy metals can increase your chance of developing pancreatic cancer. There are some hereditary syndromes or germline mutations that also increase your risk for developing pancreatic cancer. The one that we all commonly know is the BRCA1 and 2 gene that actually gives you about a 2 to 6 increased fold of developing pancreatic cancer. The one that has the highest risk of developing pancreatic cancer, which is also, this germline mutation is pretty rare, is that of Peutz-Jeghers syndrome, which has a 132-fold increased risk of developing pancreatic cancer. So it's almost saying that if you have this syndrome, you're gonna get pancreas cancer. When we look at diabetes development in individuals with pancreatic cancer, it's been shown that there's an association between new onset insulin-dependent diabetic or type 1 diabetics and pancreatic cancer development, especially in individuals who are over the age of 50 with no family history of diabetes. They are not overweight or they have a normal BMI, and they also have associated weight loss. So for the family docs out there, if you have somebody that's over the age of 50 and they have no family history of diabetes, or type 1 diabetic, and they're losing weight, this should be an antenna to determine whether or not this patient has something underlying within their pancreas and may warrant some further imaging. When you actually operate on patients now with pancreatic cancer, they also have an increased risk for becoming diabetic post the operation. So if we take out the head of the pancreas, which is known as the WHIPPLE procedure, again, I have a diagram for that for you. Individuals have a 10 to 24% chance of becoming diabetic post this procedure. If you remove the tail of the pancreas, individuals have anywhere from an 8 to 60% chance of becoming diabetic post this procedure. So how do we actually diagnose pancreas cancer? Even though that there are no early warning signs, there are some symptoms of pancreatic cancer, weight loss being one of them. Now, this isn't weight loss when you're out there exercising, you're at the gym constantly, or you're eating better, you're running marathons. No, this is weight loss when you are doing nothing extra. You're at home all day, or you're in front of the television, you're eating your normal diet, you're not exercising, but yet you're still losing weight. Something's wrong there, and you should seek help with respect to your family physician with respect of what exactly is happening. If you have stools that are floating in the toilet, or you notice oil mixed with the water in the toilet, then this could be a sign that your pancreas isn't functioning properly. So the enzymes that the pancreas actually releases are becoming blocked or not getting into the duodenum and not digesting the fat. So the fat comes out into the stools and makes the stools float and makes it appear oily within the toilet. If there's any persistent nausea or vomiting, if you ever notice that, you may have some yellowing of the eyes, which is jaundice, or itching of the skin, that's persistent with associated eye yellowing. Again, that's a sign of pancreatic cancer. Indigestion or heartburn or fullness in the abdomen. Again, if these are going on for a prolonged period of time, these are warning signs that something isn't necessarily right, and you should have these looked at. Pain in the abdomen or back. If you're developing pancreatitis, most commonly chronic pancreatitis, when you have recurrent inflammation of the pancreas. Difficult to control diabetes mellitus, and finally, new onset diabetes mellitus over the age of 50. These are all warning signs that something is going on with the pancreas and you should have a look. After you've already taken a detailed history, you examine your patients again, looking for any evidence of any masses within the abdomen, any evidence of fluid within the abdomen, or anything else that may be going on. After a detailed history and physical exam, we then go on to the imaging. The most common imaging that we use to determine whether or not a person has pancreas cancer is that of a CT scan. It's a cross-sectional image that we give IV contrast for, and the IV contrast is an iodine-based substance that once within the bloodstream, it lights up the organs. And when the organs light up, especially the pancreas now, a pancreatic tumor or pancreatic cancer, does it light up? So that's how we kind of know that, okay, there's something there that shouldn't be there. If you have lesions or spots in the liver that you're not entirely sure about, then you may want to get an MRI for that to have a better look at the liver. If there's disease outside of the liver or disease in the lung or disease elsewhere within the abdomen that you're not 100% sure about as well, then a PET CT may play a role. For individuals who are jaundiced and are not going to get an operation at any point or any time soon, they may undergo an ERCP, which is an endoscopic retrograde cholangiopancreatography, or PTC, percutaneous transhepatic cholangiogram, where we actually pass tubes into the bile duct and place a stent to keep the bile duct open in order to relieve the jaundice. And finally, endoscopic ultrasound with biopsy if there's a suspicion that this may not be pancreas cancer and possibly something else. The CT abdomen, as we see here, it's a donut-looking thing with a bed in front. So you lie on the bed, and it takes you through the donut and brings you back out. And at this time, they're shooting hundreds of X-rays. And I like to think it's like slicing you up like a loaf of bread. And it actually reconstructs the image for you to look at on a computer later on. When we do these CT scans, only 20% of people, like I said earlier, with pancreas cancer can actually be resected. When we're looking at small, little less than a centimeter nodules in the liver or within the lining of the abdomen, the CT scan is not that sensitive. So you may have to do something else. And for individuals who are actually undergoing an operation, they should not have a CT scan no older than 4 weeks, because things can change within a month. Here is a cross-sectional image or a CT scan of a patient that we had. If you look here to the right, this is their liver. This is the bottom aspect. Here's their right kidney, the left kidney, and in the center here is the pancreas. And just anterior to it is the stomach.
Look and see the people, she can't hear them and know if it's possible, she could help them.
So in this area here, this here is the mass which is associated with the pancreas. So this is our pancreatic cancer. As you can see, this paler area here, paler gray area here, that's the bile duct going through it. So this person actually presented with jaundice. This picture here shows this giant stomach in the front and the pancreas in the back with this gray line running through it. And this gray line is a dilated pancreatic duct, which is obstructed from ahead of the pancreas mass. And it's also obstructing the stomach. So these patients are presenting with persistent nausea and vomiting. They can't eat anything. Anything that they put down just comes right back up. And this final image here, again, showing the liver to the right, the kidney to the right. This white area here in the front is the stomach, which this patient had drank some oral contrast, so that's why it appears white. And then this little subtle thing here in the pancreatic tail. This individual actually went for a scan because they were complaining of some vague abdominal pain. And sure enough, when we saw this and we operated on the patient, we removed it, it was a pancreatic cancer. Now, the tumors that present in the tail of the pancreas, those are the most difficult to diagnose because there's really nothing around to cause you symptoms. So by the time you actually diagnose a patient with a pancreatic tail tumor, they have already spread to the liver, to the lungs, and there's really not much that you can do with it. So luckily, this lady had some vague pain, and the physician decided to get them a CT scan, and this was found. So when we look at our CT scans, we try and group our individuals with pancreatic tumors into classifications such as resectable, meaning that we can take it out without having to worry about damage to any other organs or removing any blood vessels, borderline resectable, locally advanced, and finally metastatic, meaning that it's spread throughout the body. So if it is resectable, meaning that we can take it out, we can operate on this patient, or we can offer this patient an operation. If it's borderline resectable, meaning that it may be impinging on those major blood vessels that supply blood to the small intestine or to the first part of the large intestine, and we're not sure if we can get it all cleared, that would be considered borderline resectable. We may want to do something else for that patient. Locally advanced is that it's invading other tissues, invading other organs, invading those blood vessels. And if you do operate on that patient, you're going to take out the tumor, yes, but you're going to leave the tumor behind. And removing the tumor and leaving tumor behind is never a good thing because the patient will not have any benefit from the surgery, and all they will have is the risks that were related to the surgery because this cancer is still there and it's still going to grow and spread. And finally, metastatic, if it's involving the liver or the lung, then usually there's no role for surgery in that case. Endoscopic ultrasound also helps to determine whether or not this thing is actually a cancer. In the picture to the right, you see it's an endoscope. So we pass this scope down the mouth into the stomach, and it has a little ultrasound probe on the tip of it. And once within the stomach and the duodenum, we can see the entire pancreas. So when there's a question as whether or not this is a cancer or not, or could this be something else like chronic pancreatitis, then you'd want to get an endoscopic ultrasound and they can do a biopsy for us. If we're not sure if it's cancerous or not, this biopsy will tell us. Again, if you have somebody with a pancreas tumor that cannot come out and they're having chronic pain related to it because these things invade the nerves within the back along the aorta, you can actually use the endoscopic ultrasound to go in and block those nerves to help palliate that patient's pain. Seeing that only 20% of people are resectable when you actually get a scan for these individuals. Some individuals you may want to go in and put a camera in first into the abdomen and have a look. And the reason why we would do this is because remember now, the CT scan can only pick up things over a centimeter. So anything less than half a centimeter or a centimeter, it's very hard to pick up and the sensitivity is pretty low. So if you suspect that there's something more going on within the abdomen, you may want to put a camera in because up to 23% of people, when you get in there, you may see nodules along the lining of the abdomen, or you may see some stuff in the liver that would tend to say, okay, this is not a patient that we're going to operate on. We're going to back up and give them some form of additional therapy. So again, it's for high-risk individuals who have your borderline resectable tumors, if you suspect that there's disease elsewhere within the abdomen. If it's a tumor of the pancreas, body, or the tail, then you'd want to scope these individuals with a laparoscopy. CA19-9 is a tumor marker that we get for these individuals with pancreatic cancer. So it's similar to colon when we get a CEA level, or to breast when we get a CA27, 29. These are markers that we follow to determine whether or not you're actually getting a response to the treatment, whichever it is that we give you. So we use that in the case of somebody that has a resectable pancreas tumor. If their CA19-9 is elevated, remove the tumor, it should go down to normal. And they would follow that in the postoperative period. So if we notice that that is now climbing back up, then we need to investigate further to see if there's any evidence of any recurrence. Some people do not produce CA19-9, and that's in the Lewis antigen negative patients, and then they may be falsely positive in patients who have biliary infections or inflammation, or even if they present with deep jaundice, they may have a falsely elevated CA19-9. Some of the differentials, so if it's not a pancreatic cancer, it could be chronic pancreatitis or autoimmune pancreatitis, but they tend to have the symptomatology that goes along with these. So they may have chronic abdominal pain, or they may have some other things that you see on the CT scan that play along to pancreatitis as opposed to a pancreatic adenocarcinoma. So in summary of the workup, you want to diagnose these individuals when they come in with their symptomatology. And the diagnosis will be based on the history, physical examination, as well as your cross-sectional imaging. You want to do blood tests. So you want to get your full blood count, your SMAC7, which is looking at your electrolytes, your liver function test, and finally you want to get your CA19-9. If it looks like a pancreas cancer on the CT scan, and you want to stage them by getting a scan of their chest as well, just to make sure that there's no evidence of lung mets. And finally, you want to make sure you get a performance score on this individual. And a performance score just kind of tells you how fit this person is in order to undergo an operation or even in order to undergo chemotherapy. There are various performance scores out there, such as the Kanofsky or the ECOG score. And they tell you, what it's like for this patient from day to day. Does this patient carry out their own activities throughout the day, or do they have to get work for or help with 50% of their activities, or they're bedridden? So it's good to know that when you're actually deciding on whether or not this patient may be a candidate for the operating room. When we look at treatment for pancreatic cancer, there's local therapy, which consists of surgery and sometimes radiation. And then there's systemic therapy, which consists of chemotherapy, immunotherapy, and targeted therapy. The local therapy or the surgical options would be that of a WHIPPLE procedure, which I kind of touched on earlier, which is a pancreatic duodenectomy, or we can remove the distal half of the pancreas and the spleen for tumors in the pancreatic tail. If there's a tumor involving the entire pancreas, or there may be a disease process that's involving the entire pancreas, then we can remove the entire pancreas. Or if the tumor is within the central aspect of the pancreas and it is resectable, then we can just do a central pancreatectomy. So the WHIPPLE procedure, what is it? It's a procedure in which we remove the head of the pancreas. So if you have a tumor within the pancreatic head, these patients tend to present with jaundice, because as you can see, the bile duct is running right through the pancreatic head, and the tumor causes impingement of that bile duct. So bile cannot now come out of the liver, and this now spills over into the blood, and you get yellowing of the eyes, itching hands and feet and skin, yellowing of the skin. You also get dark urine and pale stools. So when we do this WHIPPLE now, we remove the head of the pancreas. We also remove the gallbladder, as well as a portion of the bile duct. And then we remove the duodenum, which is this first part of the small intestine, and then a small part of the jejunum, which is the second part of the small intestine. So we take that out all as one, send that to the lab for processing so they can tell us about margins and lymph nodes, etc. Once it's out now, we have to reconstruct everything. So we have to join the pancreas back up to a loop of small bowel, join the bile duct back up, and finally join the stomach back up. As you can see, it's a pretty complex operation. It takes anywhere from 4 to 10 hours to actually perform this procedure because it varies from patient to patient, the level of difficulty. When we look at a distal pancreatectomy, it's not as, I guess, intricate as a Whipple because we're only now taking the tail of the pancreas as well as the spleen. And the reason why we take the spleen with it, because the spleen is intricately supplied by the blood vessels that run behind the pancreas. So in order to get a good lymph nodal yield and a negative margin, we take the spleen along with the tail of the pancreas. When we look at these operations, we tell people that 40% of individuals who we operate on are going to get a complication. And that complication can rise from anywhere such as urinary tract infection and pneumonia, or a dreaded complication that we worry about the most, that of a post-op pancreatic fistula. And that is where we join the pancreas back up to the small intestine. There's a hole there. Sometimes fluid from the pancreas can actually leak out into the abdomen and cause a pretty big problem. I like to believe that everybody gets a post-op pancreatic fistula because it's challenging to sew the small tube up or sew a hole up to the intestine. But there are varying levels of this fistula. Most people, when they get this issue, they don't have any change in their overall status post-operatively. They don't have any extra pain, no nausea, no vomiting. Within 5 to 7 days, they're gone home. But if you have a more larger leak, so if there's a big hole and then there's quite a bit of fluid leaking out, and these individuals now, they'll have prolonged hospital stays. They may have to be taken back to the operating room to wash out and leave drains, etc. And then again, we worry about postoperative pancreatic hemorrhage, which is a bit less rare than the fistula, but it's just as deadly. If you do bleed after this procedure, you may need a second procedure to go back and stop the bleeding. And we also tell people that from this operation, 1% of people actually died related to the operation. Systemic therapy, what we look at. So the current standard of care is actually removing a pancreas tumor or pancreas cancer that is resectable and giving chemotherapy afterwards. And usually that chemotherapy is in the form of either gemcitabine or FOLFIRINOX. Some individuals warrant neoadjuvant therapy or giving chemotherapy prior to operating. So if you have somebody with a borderline resectable, so you're not entirely sure you're going to get all the tumor out, or you have somebody with a locally advanced, and you think that if you give them chemotherapy up front, shrink the tumor down, you kind of treat any kind of floating cells within the blood, any tumor cells floating within the blood, you destroy those. And you also get an idea of the biology of this tumor. Because if it shrinks down and you notice that the CA19-9 blood level starts to come down with the neoadjuvant therapy, then you know that this person is likely going to do well with a surgical procedure if you can get them there. This just showing a study, the GI Protege 24 study, just showing the benefits of adjuvant chemotherapy after you've completely resected a pancreas tumor. The median overall survival rises from 25 months to 54.4 months. So over doubling the life expectancy. Again, currently for neoadjuvant therapy, there's really no standard of care in this area. Some individuals now are looking at giving chemotherapy even prior to operating on somebody that has a resectable tumor. So you can actually remove this with an operation, but they want to give them chemo first, again, to assess biology, to assess whether or not this thing will actually grow on chemo. And sometimes, or in a vast many patients, after surgical procedures such as a Whipple, and if they do develop a complication, they may not even get to the point where they can get adjuvant chemotherapy. So they may only get the surgery and not the benefit of getting chemotherapy on the back end. So there are proponents for giving all the chemotherapy up front, assessing response, and then after that going ahead and doing a surgical resection. Immunotherapy can also be used. There's one agent that we use, pembrolizumab, for individuals who have DNA mismatch repair genes. So after your systemic therapy, then there becomes individuals, because remember, there's like 80% of people that you can't necessarily remove their tumor. So what do you do with these individuals? And these individuals tend to present with symptoms. So some of them we can palliate. And palliate basically means relieving the symptoms caused by cancer. So in this here CT scan, we see that again, here's the liver, and then this big, large area here is the bile duct that's obstructed. You have your pancreatic tumor and your pancreatic head, and over here is your gallbladder with some stones in it. Now this patient, they presented with jaundice, and we couldn't necessarily resect this tumor. So what do you do for that patient that you can't operate on to remove the tumor, but yet they're jaundice? Another patient, they presented with gastric outlet obstruction. As you can see, this large stomach just filled with food and liquid. They can't eat anything because it's just going to sit there. And after a while, they'll vomit it out. You know, you can't remove this tumor, but yet they still have a problem. This is where our GI endoscopy individuals come into play. And this is where we can place stents into these individuals. So if you have a tumor that's blocking up the stomach or blocking up the bile duct and you can't operate on this patient for whatever reason, they may have a poor performance status, they may be metastatic, they may have locally advanced disease. Then you can use endoscopy, you go in, you put a stent across the bile duct to open it up so that they can relieve their jaundice. Or you put a stent within the stomach to open it up. So now this individual can actually eat and food and stuff can go by, and then they can get the recommended treatment, which is usually chemotherapy in those situations. And the stents can either be plastic or metal stents. Some of these individuals also, like I said before, present with severe pain, usually abdominal pain extending to the back. We end up having to give them opioids such as morphine and fentanyl patches. But if you can, if we do have the facilities available to us, we can also do, like I spoke about earlier, the celiac plexus block, which is basically blocking the nerves of the aorta in which the pancreas is actually invading. And we can do that via endoscopic ultrasound, we can do that via CT guided, or even if we were in there, say we went in for an operation and found out that we couldn't necessarily move forward, but the patient was having pain pre-op, then we can go ahead and just inject some medication along that axis to destroy those nerves. And finally, palliative radiation can also help those individuals who have unretractable pain. In those individuals who have metastatic or locally advanced disease, you should always have them do an advanced care directive. So you want them to make decisions with respect to what it is that you want to achieve. You know, so this should be done with your family members and your physician, where you sit down and determine your prognosis, try and get an idea of how long you may have to live, and then what to expect in the next few months or years, etc. And if there's any medical therapies that can be given to improve your quality of life. And you want to make sure during this time that your wishes are understood, because you may be a person that does not want to go to the ICU or does not want to be intubated if their heart were to stop or anything like this. And you would want your physicians to know this, and you want them to respect this, because if they don't know it, then they're going to go all out and do exactly what they feel is necessary to get you out of the hospital. And it's not a final thing. You can say this now, and then 2 months from now, you change your mind, and it can always be changed. So follow up now for these individuals who you've actually resected or you've done something for. You actually visit the physician every 3 to 6 months for about 2 years, and then every 6 to 12 months for 3 years after. During this time, you do a detailed history and physical examination. You do your CA 19-9 levels just to make sure that they're not rising and they're steady at a plateau. And then we also image you on an as-needed basis. So, in summary, looking back at pancreatic cancer, we know that it's quite deadly, but it's not as common as the ones such as breast, lung, prostate, colorectal. And we also know that there are no early warning signs. So some of the things that I recommend that you do to kind of fight off this diagnosis is just having a family physician or a general practice physician that you follow up with maybe once, twice a year, and you just go to them and you have a conversation with them, you tell them how you're feeling. You kind of, it's somebody that you kind of grow old with. Because if there's anything that may be off, you know, they may be able to pick it up prior to you even knowing, get you some imaging or some testing early and try and pick something up earlier than normal. As opposed to not seeing a family doctor at all or not seeing a physician at all and just going about your life every day. And then one day, bam, your eyes turn yellow or you've lost a ton of weight and don't know why. And then you go to the doctor and they tell you, oh man, you know, you have pancreas cancer, it's stage 4, and there's really not much that we can do for it. So again, it is a deadly disease, but with knowledge and information and change in lifestyle habits, it's something that we can combat. Thank you. Some references. I don't know if you guys have any questions.
Do we have any questions for Dr. Major? Dr. Major, very good, thorough talk, and leave the floor open for any questions. Anybody?
Hi, Dr. Major. Dr. Black, can you hear me?
Hi, yes, I can hear you. How are you?
Good, thank you. Thank you very much for your presentation.
No problem.
So, quick question. Are there any early warning signs for patients who may have pancreatic cancer that you could suggest would encourage people to go and have a conversation with their physician?
Again, not really. Because by the time, most commonly when patients get or they're diagnosed with pancreatic cancer, is if it's a head, you hope that it's a pancreatic head tumor because they impinge on the bile duct and they cause jaundice. The ones in the tail, there's really nothing around to kind of cause any symptoms. So by the time they get big enough, they tend to spread and individuals come in late. So that's why my thing is just trying to see a physician on a regular basis. And if you haven't, because things that we as Bahamians put off is gas all the time. Well, you got a little indigestion, that's gas. But you've been having gas for 2-3 years, you know, shouldn't you have it looked at? You know, shouldn't you have somebody investigate you somehow, whether it's an endoscopy or an ultrasound or anything like that? You know, but if you're not seeing a physician and you're not telling them this, and you don't have a relationship with a physician, by the time they figure this thing out, you know, there's really nothing that we can do. For most people.
Question, Dr. Major. Yeah. Excellent presentation, by the way.
Thank you.
My question is, in your experience, what is the general age bracket of patients that have presented with pancreatic cancer? And also, what are the signs that you look for that you deem as a favorable or successful outcome in the treatment of pancreatic cancer?
So usually it's in the 50s and 60s, sometimes even 70s. And I think we've seen somebody as low as 45 with pancreas cancer, but that's not the norm. And to say you have a successful outcome for these individuals, they actually you'd want them to undergo a successful operation where they have removal of the pancreatic head or pancreatic tail. And then there are no lymph nodes that are involved. You may have taken some lymph nodes and they don't have any lymph node involvement, so that means that the cancer has only been confined to the pancreas. They get some chemotherapy afterwards and they do relatively well. I consider that they will have the best chance of having a good outcome. And again, we look at outcome in the term of, as that study showed, say about 54, 55 months with respect to pancreatic cancer, even with all of that. But then you do have some outliers out there, because I know Dr. Francis has a patient. I think he's probably like about 4 or 5 years post pancreatic cancer resection, and he's still thriving. So again, it's not a hard and fast rule that you will fall in that category where after 5 years you'll be gone. But again, everybody has their own biology and everybody's different.
Thank you. Could I throw in another question if nobody else is?
Go ahead, go ahead.
Okay, as an OR nurse, what are your expectations in having your theater prepared, instrumentation-wise and equipment-wise, for the actual procedure, like WHIPPLE, or what are your expectations?
Well, I like to think that I'm fairly easy to get along with in the OR. So I would come in and kind of help out and show you exactly what I need. And it's the basic standard stuff that I use. So nothing special, just the retractors and then the ligatures. And I'll pick up my sutures and let you know what sutures I want. And, I play my music in the OR and then I tell you what instruments I want and you just hand them over and we get it done together.
Thank you.
No pressure for me.
Any other comments, questions?
Yes, I have a question.
Go ahead.
Yes, good night, Dr. Major. Great presentation here tonight. As it relates to younger persons like myself who early 40s and whatnot, is this something that we should be leaning towards if you don't have no issues? So your personal care physician to say, well, hey, how is my pancreas doing? Or is that a conversation that you should engage in, or is it something that, how should that come up? That's the question I'm trying to ask. After hearing such information, is like there's something on your mind now. So how is that now brought up with your doctor?
Well, again, it's not something that we screen for. Like when you have breast cancer, where we do mammograms every year or every other year after a certain age, or in men, we get prostate exams or PSA levels, or even colon exams for colon cancer. There's really no screening to look for early pancreatic cancer. So to say, go to your physician and ask, how's your pancreas? It's a difficult topic to say, have an answer for. But if you were to tell your physician that, okay, I've been feeling indigestion lately for a few months, they may give you some stuff to kind of treat it. There's no improvement, then they may bump it up to something different. Or if you've been having some weight loss and not necessarily trying to lose weight, then they may want to investigate you for something like that, depending on your age. But what I would say to kind of minimize all this risk, it wouldn't necessarily take away the risks, but things such as leading a healthy lifestyle, so exercising, 30 minutes a day for about 3-4 days a week, not smoking, the occasional drink, things such as this, kind of cutting out certain foods, processed meats, red meats, things such as this can kind of help minimize your risk for all cancers across the board. But to say, get rid of your risk for developing cancer, not really. And then the other thing too is you'd want to get a better idea of your family history as well, because you want to know which one of your relatives died from cancer and what kind of cancer was it? Because if you have somebody now that has multiple family members that have pancreas cancer and died from pancreas cancer, now this may be somebody now that, okay, let's look at a bit closer with respect to trying to get some imaging even prior to them having any symptoms. But outside of that, it's just trying to take care of yourself as fast as possible. And again, having a physician that you see regularly and them getting to know you, you getting to know them, and anything that seems off, them kind of looking into and then determining whether or not this needs to have an elevation in the investigation.
Any other questions? All right, Dr. Major, thank you very much. A very informative talk. We won't be having a monthly meeting talk in December, but remember my announcements, the 3 events that we're having: Love's Light the Tree, the Blue Rose Foundation activity on the grounds of Cancer Society. Actually, Love Light the Tree on the 27th of November, the Blue Rose Foundation activity on 10th of December, and the New Year's Eve fantasy ball by the Cancer Society. We're still working on a golf tournament for January, so that may be still coming on stream, but stay tuned for any word on that. And we'll leave it as that. One other note that I didn't mention earlier, one of our board members' moms passed away, Beverly, and we send our condolences to Beverly. I don't think she's on the call tonight, but we've been WhatsApping her and giving her prayers and condolences. Dr. Major is also a liver surgeon, so maybe we're going to come back to talk about liver cancers and liver surgery at some point. So, Dr. Major, we'll get you roped in for another talk one day. Thank you very much.
No problem.
If there are no other questions or queries, I think that we'll call it an evening. Good night, everyone.
Good night.